Good morning, ladies and gentlemen. Welcome to the Integrated Webinar 2020 with the theme of Nursing the World to Health, Breaking the Chain of COVID-19 Infection by Centro Escolar, University Manila, Philippines School of Nursing in collaboration with Budi Luhur Institute, Health and Sciences, Cimahi, Indonesia. I am Aisha Kayas, a student from Centro Escolar University.
And I'm Sir Angga Sukma from Budi Luhur Institute of Health and Sciences, Cimahi, Indonesia.
And we will be your moderators for today. Now, for the house rules, but before that, we are inviting you to use the hashtag CEU and Budi Luhur COVID-19 webinar in your Facebook, Twitter, or Instagram account. Now, we will be reading the house rules. For the house rules, the attendees should be online and the meeting room opens 15 minutes prior to the schedule. The attendees can ask questions to the speaker or sharer in the chat window. Please type in your questions and clarifications or any other messages you want to ask the speaker or sharer to know. However, not all questions can be entertained. Be aware of strong language, all caps, and exclamation points. For the third house rule, attendees in the Facebook or YouTube page can also ask questions. And the last, the attendees should answer the evaluation forms after the webinar.
These are the objectives for today's webinar. At the end of the webinar, 95% of the participants will be able to, the first, describe triage protocol in the COVID-19 emergency environment. Second, explain standard precaution of healthcare provider in a COVID-19 area, ward, and institution. And the last, determine nursing responsibility in caring for COVID-19 patient.
Now, to start our integrated nursing webinar, let us all witness an invocation for the Catholic prayer and Akmadja Karsi from Indonesia for the Muslim prayer, followed by the national anthem of the Philippines and Indonesia.
Assalamualaikum warahmatullahi wabarakatuh. Allahumma salli wa sallim ala sayyidina wa habibina wa syafi'ina wa karimina wa maulana Muhammad wa sallim wa radiyallahu tabarak rabbana wa ta'ala kulli sadatina ashabi rasulillah ajma'in. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Hamdan syakirin, hamdan naimin, hamdan yuafi ni'amahu wa yukafi'u mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalalika wajhikal karim wa li'azimi sultanik. Allahumma salli ala sayyidina Muhammad. Allahumma salli alaihi wa sallim. Allahumma ighfir lana dzunubana wa liwalidina wa li ikhwanina wa li jami'il muslimin wal muslimat wal mu'minin wal mu'minat al ahya'i minhum wal amwat. Allahumma inna nas'aluka ilman nafi'an wa rizqan thayyiban wa amalan mutaqabbalan. Allahumma inna nas'aluka husnal khawatimah wa na'udzubika min syarril 'aqibah wa su'il khatimah. Allahumma inna nas'aluka ridhaka wal jannah wa na'udzubika min sakhatika wan nar. Allahumma inna nas'aluka salamatan fid din wa afiatan fil jasadi wa sihhatan fil badan wa ziyadatan fil ilmi wa barakatan fil rizqi wa taubatan qabla al maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma hawwin alaina fi sakaratil maut wa najata minan nar wal afwa indal hisab. Rabbana la tuzigh qulubana ba'da idh hadaitana wa hab lana min ladunka rahmatan innaka antal wahhab. Rabbana hab lana min azwajina wa dhurriyyatina qurrata a'yunin waj'alna lil muttaqina imama. Rabbana zalamna anfusana wa illam taghfir lana wa tarhamna lanakunanna minal khasirin. Rabbana ighfir lana dzunubana wa israfana fi amrina wa tsabbit aqdamana wansurna 'alal qaumil kafirin. Rabbana taqabbal minna innaka antas samiul alim wa tub 'alaina innaka antat tawwabur rahim. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun 'alal mursalin walhamdulillahi rabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Mari. Ya Pak. Amit.
Namanya ganti APD itu juga open. Nah, dia cepatkan dulu. Kita tinggal.
Now, to formally open this program, let us all welcome the Dean of Centro Escolar University School of Nursing, Dr. Elvira L. Urgel.
Our distinguished speakers, Dr. Regina Berba, Ms. Monina Hernandez, Ms. Dede Malwati, the sharers, Mr. Mark Galimpin, Mr. Christian Roy Bangloy, Ms. Jennifer Lim, and Ms. Ermi Gumilar. Members of the faculty, guests, students, good morning. Since then, the integrated seminar has been envisioned as an avenue for solidifying the knowledge of nursing students as they participate through a series of relevant, highly cohesive, and dynamic topics that is responsive, timely, flexible. It was beyond one imagination. Then the seminars such as conducted confines of the auditorium will be translated to a webinar that transcends walls, resonates distance, and transgresses time. This was then an application of knowledge development, as true learning is one that is enriching yet flexible. Combining this with the great desire to be opportune bearers of solution in this highly challenging time, we welcome you in this webinar that is a product of collaboration between two institutions of higher learning and growing together to transfer and create knowledge with the end of expanding knowledge, spreading awareness, and serving as mediums of knowledge transmission as the world passes through the greatest challenge of all time.
Dean, nakamute kayo, Dean.
Knowledge and learnings can be likened to a seed that has been planted, transferred into an appropriate environment, nurtured and cared for. For several years, most of the participants here have nurtured and cultivated their own knowledge, whether in their own schools or universities. But today is a day where those knowledge will come to a full circle as the distinguished speakers rounded up key insights and contributes to the growing knowledge span and the sharers expand horizons on what is happening on the real world and in their own workplace. There is nothing more exciting than to take part in this exchange of academic ideas, which is ultimately worthy, significantly and timely. The team Nursing the World to Health, Breaking the Chain of COVID Infection, brings us an inch closer to what everyone is envisioning, to bring the world back to health and for us to be back in the new normal. Nurses and the allied healthcare team are in a significant position at this time as they played the role of frontliners. Our dear students are now standing on a critical time as soon as you will be joining the ranks and will be the frontliner. While this is quite frightening and uncertain, it certainly brings you great opportunities to leverage yourself and apply what you have learned. As they say, the ship is not meant to be at the shore, as it is meant to hurdle the tides and waves. Hurdle the tides and waves and with great paddles of knowledge, a strong vote of courage, and a compassionate and caring heart that nurses and breaks the chain of infection. As we join hands in the year of the nurse, may we constantly be reminded of our great responsibility and the huge role that we play in maintaining the health of the world. Allow me then to extend my gratitude to everyone who made this possible as I welcome you all to the Integrated Nursing Webinar.
Webinar
Mabuhay
international
tayong
ba?
lahat. Terima kasih.
Thank you so much for that wonderful opening remarks, Dr. Elvira L. Urgel. To introduce our first speaker, she was a clinical nurse specialist in infection prevention and control for the medical services, adult rehabilitation and health of older people services, women's health services and district nurses, pediatric services and outpatient services of Waitemata District Health Board and Counties Manukau Health, Auckland, New Zealand, a board member of the Nursing Council of New Zealand, and was elected in 2017 as director of the New Zealand Nurses Organization. May we welcome Ms. Monina Hernandez.
Hello. Hello, can everybody hear me? Yes?
Yes, ma'am.
Yeah, okay, hi. Yes, good afternoon, everyone. To our distinguished guests who are here, good afternoon, Dr. Elvira Urgel, Dr. Teresita Barcelo, Dr. Pearl Cuevas, Dr. Regina Barba, to our distinguished academics from Indonesia, good afternoon to everyone, and also to our students and our viewers. For this afternoon, I'll be sharing actually our experience here in New Zealand when it comes to the implementation of standard precautions. So I hope you would bear with me. I understand that I'm given 20 minutes to do this. So let me start the discussion by sharing my slides. Okay. All right. So good afternoon, everyone. Like what I said, so I'll be talking about standard precautions for healthcare providers in a COVID-19 area. So specifically, I'll be talking about our experience here in Auckland, New Zealand. And as discussed earlier, I've been a clinical nurse specialist for infection control in two of the district health boards here in New Zealand. And just as a brief explanation of how we are in New Zealand, we actually have 20 district health boards across the country. There's around 5 million people in the country. And in those 20 district health boards, of course, there would be tertiary and secondary hospitals. And they are scattered in different regions. And with that, I have worked in two of them. All right, so let's continue. There you go. Sorry. All right. So the learning objectives for this afternoon is after the discussion, the learners will be able to explain standard precautions for healthcare providers in a COVID-19 area or ward or institution and determine the nursing responsibilities in caring for COVID-19 patients. You would notice that I actually removed the other objective. If you would remember, there's three objectives to the seminar. The reason being I'm not going to focus on triaging. I'll just be focusing on the two objectives. And before I go into standard precautions itself, I just want to explain what we have done here in New Zealand. What you can see in front of you is actually a logo that speaks for itself. You would see there, it says there, Unite Against COVID-19. And this is actually the public face of the national strategy of New Zealand to stamp out COVID in our country. And the reason why this is very important for us is because of this logo, everyone in New Zealand knew what they need to do when it comes to COVID. And that means that they indeed have united, even, united in terms of staying at home, in terms of following the instructions, in terms of cleaning their hands, in terms of wearing face masks, all of that. And that's one of the reasons why we can proudly say that we have come out of lockdown as of the weekend, as of a week ago. And well, as of yesterday, we've got 2 cases, but then for 23 days, we're proud to say that we never had new cases. new cases of COVID, of course. All right. Again, just as a brief explanation of what we did here in New Zealand. So we had a national action plan. The thing is, if we're talking about standard precautions, more often this is applied in acute care settings. But if we have a pandemic, we're not just talking about sick people. We're also talking about preventing the transfer of the microorganism, which is COVID, to people who may potentially have it. And that's why it's very important for countries not just to focus on who is sick, but also to focus on the well people because they may be vulnerable to getting the disease itself. And with that, I can proudly say, of course, that what we did here is very comprehensive, and at the same time, it addressed all areas that deal, that affects or all factors that needs to be dealt with when it comes to pandemic management. So you would see here New Zealand strategies to eliminate COVID-19 and to stamp out transmission within affected clusters. These clusters, we're talking about positive cases, for example, in certain communities or certain faiths, for example, because you know how people, when they go to church, they congregate, and with that, the microorganism can get transferred to other people easily. Apart from that, there's groups of people who's been socializing, and with that, of course, some of the cases have been linked to those groups. So those are the clusters that I've been talking about. So the mission of the National Action Plan is, of course, to unite against COVID to keep New Zealand sustainable and New Zealanders well and safe. And together, we will do this by protecting people's health, slowing the spread of the disease, and putting New Zealand in the best position for recovery. You will notice that I have actually highlighted three important words there. The first thing that I want to emphasize is the word New Zealanders. Our national action plan focused on people, preventing the transfer of microorganisms to people, and making sure that people are safe and well in their homes. Apart from that, with the National Action Plan, it also addressed its potential implications on our economy. And that's why I also highlighted the words New Zealand sustain to keep New Zealand sustainable. And the reason for that, again, is because we know very well that because of the pandemic and because of the lockdown in a lot of countries, that has brought about detrimental effects to economies. And apart from that, of course, I've highlighted the word together because we know very well, our government knows very well that a single individual or the prime minister alone cannot address the health problem itself. It has to be a united effort. That's why I showed you the logo of the face of this national action plan, Unite Against COVID, because we were united by our government under the leadership of our prime minister so that together we can fight against COVID. And of course, we know that we have achieved this goal if, of course, at the end state, you would see there that an effective transition to a steady state, longer term management of the response to COVID 19 has been completed without any loss of the response momentum. And that's where we are at the moment. Another thing that our national strategy emphasizes is actually being kind. Because we know very well that, again, in a pandemic, people might feel threatened, people feel stressed, and there may be issues of racism. And that's why being kind is, it's one thing that's being passed on. The value of kindness being passed on, or you could hear a lot of New Zealanders say this every so often, whenever they would go to the groceries, whenever they would go outside, have a walk, engage in sports. Be kind, because all of us are undergoing this very stressful moment. All of us are together in this crisis, and we need to support each other. We need to be kind. All right. And of course, in our country, again, we've got four levels. These are the alert levels. Everyone here in New Zealand knows this. We were in a lockdown that's level 4 for several weeks, and then we went down to level 3, and then level 2, and now we are in level 1. So level 1 means that the disease has been contained, and that's why we can move around the country now, but the borders remains to be closed to international visitors, but it's open to New Zealand citizens. All right, so let's go into standard precautions. But before we go into that, of course, just as a brief discussion again about COVID, you know very well that it's a respiratory virus and it can be transmitted through person to person and also person to person contact, but at the same time through the droplets of an individual as they speak, as they sneeze, as they cough. And that's the reason why we should always remember that we can also get the microorganism not just from the other person but also from their droplets that may have settled on surfaces. So those surfaces could include tables, chairs, equipment, everything. And by definition, standard precaution means that as a nurse or as a health worker, you are conscious of the fact that you may get those bugs from other people's blood, body fluids, non intact skin, and mucous membranes. And that's the reason why you are going to put a barrier between yourself and someone else's blood, body fluids, non intact skin, and mucous membranes. And of course, the reason why we need to do this is because we need to reduce the risk of transmission of both identified and unidentified microorganisms. So this is not just COVID, this is also other microorganisms. Standard precautions, there are 8 elements to it. What you would see in front of you would be hand hygiene, personal protective equipment, respiratory etiquette, sharps management, waste management, cleaning, sterilization, and disinfection of equipment, linen management, and environmental cleaning. For other countries, they may have added a few more elements, but for New Zealand, I can summarize that into 8. All right, so we know very well standard precautions deals with hand hygiene, the single most important way of preventing the transmission of microorganisms. And as health workers, we should be very familiar with the 5 moments of hand hygiene as advised by the World Health Organization. So that's cleaning your hands before and after touching a patient, before and after doing a procedure, and also after touching a patient's environment. And again, the reason for that is because COVID might settle on surfaces. And with that, if you don't clean your hands after touching surfaces inside the patient's room, you might get the microorganism from those surfaces. That's why you need to clean your hands. Apart from that, of course, personal protective equipment. These are the personal protective equipment that we use here in New Zealand. I understand that in other countries you use a different, probably a different brand, but also a different style of PPE, but I guess they serve the same purpose. So what you have there is a yellow gown, which is impervious in the front part, but not at the back part. And that's why we keep on telling our nurses that make sure that when you tie the ribbon, make sure that your back part is covered properly, because otherwise, if somebody somebody's bleeding or someone is experiencing or manifesting projectile vomiting and your back's turned on that patient, your uniform might also get contaminated because of those blood spills or body spills. Apart from that, we've got not N95, surgical mask, of course, and then we've got gloves, and then I call it goggles. Sorry, it's eyewear. I keep on saying goggles, but it's eyewear. All right. And again, of course, as nurses, we know very well that we need to wear this PPE if we think we will be exposed to blood and body fluids, non-intact skin, and also mucous membranes. Next, we've got respiratory etiquette. I guess this is the same in any country. And in fact, this is also being encouraged, of course, by the WHO. So instead of coughing into our hands, we are encouraged actually to sneeze up our sleeves, not in our hands. And if we do have to use our hands, make sure that you wash your hands or clean your hands after coughing or after sneezing. Same thing with physical distancing. Of course, we know very well that the microorganism can be transferred from within 2 meters distance. And that's why during our lockdown, for example, 2 meters distance is being implemented everywhere else. The reason being that's how the bug or the microorganism is transmitted. Next, we have sharps management. Again, this is part of standard precautions. This is the usual, to be honest. And that means that as nurses, we have to make sure that whenever we will use sharps, we dispose of them at a point of use container. So that's a yellow container that you can see in patients' rooms or probably in the nurse's station. What's important is that you don't carry around the sharps that you've used on your patient, because otherwise, of course, you may be exposed to contaminated blood or body fluids from your patients. Next, we have waste management. Also, this is very important. Anything that comes from the patient's environment should be discarded properly. So, if we're talking about infectious patients in isolation, for example, we know very well that yellow is the universal color for anything infectious. So, if you have to change their wound dressing, you have to dispose of that in a yellow bag. Whereas, of course, other things, food stuff, for example, goes into a white bag. So here again in our hospitals, all of the health workers, not just the nurses, doctors, healthcare assistants, orderlies, they know very well the importance of the color coding for our rubbish bin. Next, we also have sterilizing and disinfecting. There are some equipment that cannot be reused. And the reason for that, of course, is they're single use. So an example of that would be scissors that you will use for wound care. If you reuse that, of course, that's potentially contaminated, but at the same time, it may not be as sharp as it used to be. And that's why we keep on reminding our health workers that if it's single use, discard it. Do not reprocess it because of two things, like what I said, the sharpness and also the potential for it to become a fomite and carry microorganisms around or transmit microorganisms around. Next, we have equipment decontamination. This is very important because, like what I said earlier, the microorganism actually lives on surfaces. We know that it may thrive for around 2 hours to even up to 7 days on different types of surfaces. And that's why if you're using a BP cuff, for example, on one patient, and even if the patient does not have COVID, make sure that you clean it after before you use it on another patient. But of course, if the patient has COVID or if the patient is in isolation, we do not encourage nurses to use the same equipment on other patients. We always say that please make sure that you have a dedicated equipment for that patient alone. So that means, for example, if I've got COVID or I've got other infectious diseases, a nurse will use the same BP apparatus, keep it in my room until I get discharged. It's not supposed to be used on other people. So anyway, so what we have here are surface detergents that we use for bed frames, lockers, bedside tables, phones, trolleys, everything else, even cows, computers on wheels. I'm not going to recommend any brand names. For surface disinfectant, of course, we use this in isolation rooms, and it's part of our outbreak management. Then we also have linens. We know very well that linens are fomites. We don't change our patients' linens every day. Sometimes they keep it for like 5 days or even a week, or even until they go home. And with that, of course, they should be cleaned properly. So linens are supposed to be bagged and secured in a room, in the same room where the patient is, using standard precautions for handling infected linen. So that means if you're a nurse, you're trying to remove the beddings of a patient's bed, of course, make sure that you wear your gown, your gloves, and also if you think you will be exposed to aerosolized materials, make sure that you also wear a mask. So all linens are supposed to be placed in an impervious linen bag. So it's a yellow top bag or a yellow linen bag. And linen awaiting removal does not need to be stored in separate areas. I understand that in other areas or in other hospitals, for example, the linen bag gets stored somewhere else before it gets laundered. So in New Zealand, what we tell our nurses, healthcare assistants, all of the health workers is that they have to leave the linen in the patient's room until the room gets decontaminated itself. Then, of course, environmental cleaning is very important. So we're talking about routine cleaning, but then if it's a COVID area, the frequency of the cleaning becomes more frequent. So, for example, in a non-outbreak area, a room gets cleaned once a day, but if it's an outbreak area, then that room will have to be cleaned every shift. Again, it depends on the hospital and also the district health board. Of course, with all cleaning, standard precautions are being implemented by the cleaners themselves. So even the cleaners are educated on what PPE they need to wear and also the chemicals that they need to use when they clean the bedside and or the room itself. Next, I also opted to just show you what we do to our patients when they're in isolation. So, if a patient has been identified to have COVID or is a suspected COVID case, um, of course, apart from the standard precautions, we isolate them. So that means in an isolation room, this is what we do. So as nurses and health workers, they make sure that they clean their hands before wearing gloves, and at the same time, they wear, of course, a masks. So you would see there that N95 is worn if an aerosol generating procedure is carried out. An example of that would be suctioning, or if the patient has uncontrolled coughing. However, if the patient does not have any of these, to be honest, we only wear surgical masks. The other one is eye shield or face shield. You would see there that it's a Y, it's a yes, so that means it has to be worn all the time. And the last one, of course, is a gown, and the gown that's a yellow gown. And the patient has to be placed in a single room with its own ensuite, so its own toilet, and the door should remain closed. And of course, there should be a dedicated equipment. That means the equipment used in that patient should not be used on other patients in the hospital. Apart from that, it's very important for us to communicate with other health workers. So we also make sure that we've got posters outside the patient's door, just as a means of communicating with health workers, with even with the visitors, that the patient inside this room has a certain has a certain infection. So in this case, if it's COVID, that's droplet and contact isolation. So this is the type of poster that you would see in front of a patient's door. Apart from that, I mentioned earlier that it's very important for pandemic planning or pandemic management to involve the population. So I will go out now of the hospital setting, and we will go now into the public space. So in the public space, even New Zealand citizens, they are informed of what they need to do so that they would prevent COVID transmission. The reason being, of course, we know that people can get it from trolley carts, grocery carts, for example, or from riding the bus, for example. So that's why even the public should be educated properly regarding COVID. So you would see here posters that are produced and are posted all over the country, just to remind everyone that they need to wash their hands, they need to sanitize their hands before going inside a restaurant, for example, or a grocery, and also they need to clean and disinfect surfaces if it's potentially contaminated. Other reminders include coughing or sneezing into their elbows, staying at home if they're sick so that they won't transfer bugs or microorganisms to other people. And then, of course, this is the summary poster of all the reminders that's being put out there in the public space. This is a picture of a COVID drive-through testing center. So we test our potential COVID patients through drive-through testing centers. So that means they're not encouraged to go to the hospital if they think they've got respiratory infections. What they do is they are encouraged to call a health line, and through the health line, they're given directions as to where they can go so that they can be tested for COVID. And then these are just pictures of Filipino nurses who are in testing centers here in New Zealand. There are around 6,000, Filipino nurses in New Zealand, and they're very active during the pandemic. They're saving lives, and it's what their contribution to healthcare is very important in New Zealand. Again, a picture of Filipino nurses at work, just as a reminder that we contribute a lot in terms of preventing the spread of COVID in this country. And like what I said earlier, we enjoyed 23 days of not having a new case. But yesterday, unfortunately, we've got two positive cases. But these two positive cases are actually New Zealanders who came home from the UK. So they came home last week, a week ago, because their a parent is sick, and with that, of course, probably they were not aware that they may be harboring the microorganism, and it turned out that they did, and that's why we've got 2 new cases of COVID as of yesterday. None today. All right, and this is, of course, a picture of our Prime Minister and the very beautiful Jacinda Ardern. And she's very thankful of the team of 5 million. That's a 5 million people in New Zealand who united against COVID. They stayed at home and they saved lives. And of course, that's the end of my presentation. Thank you.
Okay, thank you so much, Mr. Monina Hernandez. Now to share his experience about the topic Triage protocol in the. I'm sorry. Thank you so much, Miss Monina Hernandez. Now for our second experience about the topic Triage protocol in the COVID-19 emergency environment. Our second sir is a graduate for ready of the Fatima University and is currently taking up the Master of Science in Nursing, Medical and Surgical Nursing at Centro Escolar University, Manila. He is now a staff nurse in the Department of Pediatric Ward 9 and also UP Agnayan ang Pahinumukot, volunteer at the Philippines General Hospital. Please welcome Mr. Mark M. Galempin. Time is yours.
I am a nurse at the Department of Orthopedic Ward since October 1, 2012 up to February of this year. I was assigned first at the COVID unit, which was previously our spine unit and was transformed and remodeled to cater COVID-19 patients. After several days to weeks, we became one of the referral center within Metro Manila as designated by the Department of Health. To cater a larger number of patients having COVID-19, the Philippine General Hospital allotted 140 beds and transformed wards 1, 2, 3, and 4, medical ICU and surgical ICU, and some floors at the pay wards. During our second round of COVID wards deployment, we were assigned at Ward 1. Initial number of patients then catered was 22. We have 4 nurses, 1 charge nurse, and 3 bedside nurses. We have 1 resident on duty during the night and 2 residents on duty in the morning and afternoon shift. We also have 1 utility worker and 1 nursing attendant during the night and 2 nursing attendants, 1 utility worker during the morning and the afternoon shift. In this video, you will see a day in the life of a nurse working at the COVID ward of the Philippine General Hospital. So, let's go!
So hello, forgive us. What we introduced before, the sharer that we introduced, his name is his name is Mr. Christian Roy M. Bangloy. Um, he is a graduate from the University of La Salle College of Nursing who underwent advancement program in clinical nursing in 2010 at University of the Philippines, Philippine General Hospital, hired by the same institution in 2012, and he became an infection prevention control nurse coordinator up to the present, assigned at the COVID unit of Ward 1. So what you have seen in the video is his experience about the life of being a nurse here in the Philippines as he take care of the COVID patients at Philippine General Hospital. Now, we will introduce our second speaker. For our second speaker, she is a consultant of the infectious disease section and the division head of adult medicine at the Philippine General Hospital, most known to many as the chair of the Hospital Infection Control Unit or HICU of the Philippine General Hospital, as she has held that post since 2004. Thus, survived through the challenges of the SARS in 2004, the influenza H1N1 in 2009, the MERS-CoV in 2012, the Ebola scare in 2014, and the year in and year out dengue and leptospirosis outbreaks. She has been working very closely with the COVID Central Command Team of the PGH since its operations as a COVID referral hospital and has been directly orchestrating the key strategies on infection control in the COVID pandemic response. She considers this COVID-19 pandemic the greatest game changer of our lives, greater than any of us. Dr. Regina P. Berba.
Hello, everybody. I'm very honored to have been invited to this integrated webinar, and I'll be talking about COVID triage management. So, this is the context of the lecture, and I'd like to just share with you things that would be important in setting up an emergency or a triage area in the context of a COVID pandemic. So, just like Nurse Bangs, I will be talking more about our experiences as a COVID referral center. So, right now, let's begin with talking about what we know now about the virus and how it spreads. And this will give context to how we will prepare our facilities to be able to triage well persons who might have COVID. So we're now familiar with SARS-CoV-2. It's a novel virus with the corona, which is due to the appearance of spikes on its surface. So these are like electron micrographs of the virus in different parts of the body. So this is, for example, pictures of the actual virus as it tries to enter a cell inside the human lung. And these are other pictures as the virus is depicted inside a cellular space within the tissues of the human body. So we know that the COVID virus is transmitted mainly by droplet infection. It's a human to human transmission. And it's believed to be, as our first speaker said, mainly due to respiratory droplets. So, what does this mean? This means that when a sick person, when a sick infected person starts to either cough or sneeze or maybe even talk or sing or speak in a loud voice, there are respiratory droplets that are spewed out into the space around him. So it's estimated that within 1 to 2 meters around that person, it's possible that the infectious droplets may fall into unsuspecting people around that person. So, but this picture, if you try to remember, maybe this is the most important picture of my slide presentation, and it came from this reference that it could be infectious, and if you happen to be around that area and without any protection, like the personal PPE that Miss Manina talked about earlier, then you might be at risk for getting infection. That's why we need to really plan and prepare. So From large droplets, they could transform into fomites if these droplets fall into the environment or the surfaces around that person. And there's a huge difference between the amount of droplets that can come out of that infected mouth if the person practices proper cough etiquette. So let me again reiterate to especially our students that there are two main modes of transmission. It's the directly the droplets coming from the mouth of an infected person, and secondarily the droplets falling into surfaces that may be touched by your hands that you failed to clean or disinfect, touching your nose and mouth, causing again a possibility of infection. So this is a photo of what happens to all these infectious droplets around us. After a person coughs, it's possible that these droplets are spread around the environments where that person is. And here, it has been found by experiments that if the environment does not undergo any regular cleaning, the coronavirus may actually stay alive for long periods of time. And they've documented this in various environmental media like plastic 5 days, paper 4 to 5 days, and so on, as seen in this picture. So now, what's this issue about the airborne? So it's this is still under contention. So some people believe that when the droplets evaporate, the main liquid portion of the droplets may evaporate. They end up as really very, very light material. And some people theorize that this droplet nuclei may actually stay suspended in the air and may cause airborne transmission. But the WHO still says that mainly the modes of transmission is respiratory droplets. So that means it could enter into our mouth. So you see in this picture, the virus with the spikes or the crown can actually enter directly into our nose or our mouth and get into our respiratory tract, causing all the illnesses that are related or associated with the COVID-19 illness. Okay, so what are the symptoms of COVID-19? So I wrote here in English and in Filipino what the extended symptoms are now identified to be associated with the diagnosis of COVID-19. It's not just fever, cough, or shortness of breath, but it also includes now diarrhea, sore throat, headache, feeling very tired, chills, and loss of smell or taste. So when we see these patients in our triage areas, we need to ask all of this to our patients because sometimes our patients won't necessarily volunteer that they may have symptoms that may be regarded as possibly COVID-19. So, when is the person most infectious? It's actually the time that these symptoms occur. So, when a person, for example, when a person wakes up in the morning and feels ill, that's the actual period of time that the patient is most infectious, just around the time that the symptoms start to appear and a few days after. So when you look at the mapping of what happens to a patient from the time he is exposed to the time he develops some symptoms, then it's actually just around the time that he manifests any of those symptoms that we talked about earlier. And that hangs around for a few days, maybe up to 7 to 10 days. So here, this is some drawings from Dr. Wolfel and group telling us that after several days, the amount of virus that is release from an infected person starts to go down. Highest around the start of the symptom, you see at the very left side of the graph, and then slowly goes down as the days passed by. So right now, the DOHR is telling us that after the 14th day, you probably won't have any infectious viral particles anymore. So that's also seen in the study of Dr. Wolfel, showing us that the positive culture, viral culture, sort of ends around eighth day or after the first week, and then afterwards, all the rest of the viral cultures have been negative from the previously infected sick people. So what happens to the patient? So we need to just really keep in mind that many of these infections are actually mild. It could be more than 80%. That's why when we listen every day to our ministries of health or departments of health, we hear that there's a large number of people recovering. That's because many are mild and many recover. Very few get sick, and even fewer actually may die from the infection, and the fatality rate is said to be anywhere from about 2 to 4% reduced over time now. There are some controversies, so we need to just keep in mind that when there's people saying it's airborne transmission, but overall, WHO will say that unless you're doing aerosol generating procedures, most of the time the transmission is droplet. Okay, and these are important concepts because it will guide what personal protective equipment you need to wear. Okay. So we've also shown earlier that the virus may survive in various materials. So that's the reason why we need to keep on cleaning the areas around us. So if we're going to set up a health facility or work in a health facility, we need to like keep the environment really clean with constant disinfection. What about other materials from the person, specimens from the person other than respiratory secretions? So they've seen that sometimes the laboratory is able to detect the virus from the stool, the blood, and the ocular secretions. But what this just means to us is just like what Miss Monina told us earlier, we need to really practice standard precautions whenever we have to handle any of the secretions of infected persons. Okay, and about uncertainty in the blood, it just tells us that, again, to be careful when we're handling blood products and needle stick and sharps, because that might lead to some needle stick injury management problems. But overall, this will not lead to a new infection. So for the students, if we are asked what we know so far about COVID-19 and the virus, we will have to say, or this is what's the best answer would be, that right now all evidence support person to person transmission, which happens mostly during close exposure. That means the unsuspecting person is within uh, 3 to 6 feet or 1 to 2 meters distance from the infected COVID patient. The transmission is primarily by respiratory droplets, and it can the droplets can land in our mouths, noses, or eyes, or inhaled into our lungs, or there might be droplet nuclei left in our environment that we might touch and then eventually also get into our mouth, noses, and eyes. And airborne transmission is currently thought to be unlikely, except when there may be aerosol generating procedures. Okay. So when we're trying to having all of these concepts in mind, then we proceed to like trying to optimize how we will plan out early triage. Okay? And this is all to limit the amount of COVID 19 inadvertently entering our health premises. So, when you work in a hospital, the last thing you really want to happen is there is suddenly a COVID 19 patient in a place that you're not expecting him to be there, and then you're all caught unprepared. So it's very important that we really map out how our systems and our operations would be once we plan to be um, a COVID caring health facility. So again, physical distancing is something that we need to just keep in mind because that will help us while we're taking care of our patients not get the infection. Here is just it's just showing us uh, what social distancing can do in the community or even when we're working in our health facility. That when we do social distancing or physical distancing, there is really less people who will get sick. And the less people here are manifested by the pink dots. Okay. Rule number two, make sure that in your facility there's lots of hand hygiene. And rule number three, that at this point in time in the pandemic, maybe later on it will be lifted, but right now the rule is for all of us to wear our face masks. And especially the students, when you get into the health facility, make sure you're not just bringing in your face mask, but you know how to wear them properly. So the colored part of the mask is always facing outside, and we need to cover our nose, our mouth, and keep it there. Do not touch the outside surface of the mask so that you keep your hands clean also and dispose them properly. The important rule number three is very, very important. It might really be life saving. You don't need expensive N95 mask in everyday work. You just need to wear the surgical face mask properly. And rule number four, as we said earlier, is to disinfect all the commonly touched surfaces. So, keeping all of this in mind, we can actually plan the whole emergency room and the triage areas quite well, just having the principles and the basics of COVID 19 transmission. There's this hierarchy of controls that starts off with engineering controls, administrative controls, and the use of personal protective equipment. So what do you mean by engineering controls? So this means for us in PGH, putting some things that logistically and in the infrastructure you put so that it's easier for people and for patients to just manage COVID 19 in a very more efficient way. So for us, it meant instead of individual rooms, it was more efficient to cohort or put together the beds 2 meters apart in one big ward. We kept the single rooms for persons with special needs. We started to put a lot of new systems to control the ventilation. You need to be able to map out in your emergency rooms and in your other wards how the air, clean air would come in and where it would go. You have to be able to direct the velocity and the direction of the air that comes in and goes out of your facility. You want the dirty air to be passed through some kind of cleaning, which usually may be through UV light or HEPA filter, so that it does not go into the to the immediate external environment and infect people who are passing by. Engineering controls also means putting a lot of hand hygiene equipment in place and some air purifying systems. So, as Ma'am Manina said earlier, communication and a lot of signages is important because it will guide where people can go and not go. It will guide where your patients will go and where your healthcare workers may pass by. So we actually divided the entire hospital into green zones. So green zones are safe places. People can walk there. There's the red zones that are not where you are not allowed. People are not allowed because that's where the patients are. And there's the safety net, the orange places where you have to be cautious. It's relatively clean, but those areas are left for the healthcare workers. So we've illustrated all our floor plans into colored schemes so that people knew exactly where they can go. And we defined some paths so that people were moving from clean to dirty and will not go back and infect themselves. Okay. There is a place called Dawning. That's where you can put on safely your PPEs before you enter the dirty wards. And there's a place called doffing. So you need to identify all those areas in your facility. If you don't have them right now yet, then it's important that you re-examine your hospital areas and identify a definite donning area and a definite doffing area because that will help keep your healthcare workers safe. So here, as you can see, there's like green zones, red zones, and orange zones. And you can map that out in your own facility. It could be just one floor, but we try to make it very clear for all areas. So even our operating rooms and operating complexes will have this green, red, and orange zones. And finally, the one that's closest to the heart of many healthcare workers and was shown very nicely by Nurse Banks earlier, the PPEs, no? So PPEs, and that was shown also by Miss Manina. Our experience are, our experiences are similar. We actually put levels. If in New Zealand they put alert levels for the levels of alert in the country, here the levels are for the levels of risk for the healthcare worker. So there's the lowest risk. So people who don't see patients, they just stay in the office, yan. So they just need surgical mask. Some people um, take care of patients, but they're non-COVID patients. So we call them level 2, and they need surgical mask and an eye protection. And then there's the people who need to go to the COVID wards. So they take care of patients. So we feel they really are at moderate risk for getting the COVID infection. So we equip them with really broad, very protective materials like a gown, an N95 mask, goggles, or face shield. Plus, some people prefer to have booties. So we try to identify them, and the highest risks are the level, we call them the level 4. So these are the ones who need coveralls and people who stay in the wards for long periods of time. Like, I'm sure Nurse Banks showed you how to wear the coveralls earlier. That's because they stay in the wards for totally over a period of 8 hours. So we try to show
Okay,
the
remind si Dr.
piece
Berba, 5 minutes left. Here.
in illustrated infographics so it's clearer. So this is level 1, just the mask. Level 2, the mask with the face shield for non-COVID areas. Level 3 are we call them complete PPEs with the gowns, the N95 and the eye protection and the gloves, and of course the level 4 with the coveralls. It's actually very complex to put this together. So we have a lot of before for the students, before you even think about going into the emergency rooms or any of the areas in your hospital, you really need to study how to put this together. And both videos, we've made videos of how to put them. These are how our donning and doffing areas. So make sure you go here and put on your protective gear so that you are ready to face your patients quite well. Don't rush. Give yourself enough time to don these areas. We actually have what we call safety officers. Their job is to make sure that the donning and the doffing of this very complex uh, personal protective equipment are done perfectly well. So the level of risk goes down. Okay, so we also try to flood our areas with a lot of infographics in the local language and in English, so that people understand what's happening. Okay, in the triage area, we recommend the use of surgical mask plus a face shield and gloves as needed to comply with the needs of standard precautions, droplet precautions, and contact precautions. Okay. So if I work in the ER, there's a lot of fear. What happens to healthcare workers after they work in the ER? But our answer is, as long as we follow all the rules, we follow all the required PPEs, then we are not at increased risk. So we need to really wear our PPEs, and the high risk exposure happens when a healthcare worker enters, like let's say, a red zone without the adequate PPE. So there's the high risk, the medium risk, and the low risk. So let's study all of the precautions so that we don't get ourselves into high risk exposures unnecessarily. Okay. So again, we were able to summarize the levels of risks, because sometimes this is the one that's I think the one that makes people really very anxious during work. What happens and how much risk am I exposed to whenever I work or may meet a patient with COVID? So we say that we're able to reduce the risk to low levels if we follow the rules, the environmental, administrative, and the PPE rules, plus all the zonings. If we follow all of them, we can get the risk down to very low. Okay. So um, I will go to working in the triage or in the ER. I will refer you to the website of the CDC. There's like teaching materials that have been just updated on the last week of May of this year. So they're very current. They're SOPs for triage of suspected COVID patients. These are their slides, and they define what triage is for the students. It's important when patients arrive in the hospital that somebody or some place immediately tries to sort out what are the needs of this patient and where should the patient go, so that he or she does not keep on walking aimlessly around the hospital. And if he might be a COVID patient, he might already be starting to infect other people by going around the hospital. So we don't want situations like that. So it's important that we put already a triage area in strategic places in the hospital, so you catch all the potential patients. Okay. So what can patients do? We need to keep on like trying to train and inform our public on what they can do and how they should visit our triage areas. We most of all ask them, if especially if they're ill, to wear a face mask, and just inside the gate, tell the person in the desk or a registration desk about what he feels, so that the persons from the hospital in the triage area can quickly evaluate the needs and direct them accordingly. What about healthcare facilities? What can we do? So we need to really prepare. So we have to set up our and equip our triage areas. We need to set up a good respiratory waiting area, a place where they can stay without necessarily infecting all other people around. We need to like write down a triage process that is very clear, and then we need to train our staff on what these processes are, so that there's no chaos or confusion. It's good to have some kind of a hotline in your institution, so that maybe some of the visits may be avoided if you're able to address the concerns of certain individuals. So that means they don't need to go to your facility anymore if they just need something for their headache or something for a painful knee. So, and you can then spend more time and take care of people who really need your attention through the emergency room. So have a hotline and consider options like telemedicine, especially in this pandemic season, to help support and your operations and reduce unnecessary visits. Now, it's important to equip the triage. So, just like what I showed you, prepare engineering controls, administrative controls, have a lot of signages, and stockpile your PPE so you're ready. Your triage is ready. Have these posters in place so that people would know where to go. You can equip your triage with things that will also reduce the possibility of passing infections from patients to other patients and to healthcare workers. So that means if it's about putting up barriers like the acrylic plastic barriers or plastic as we use them, or glass, then do so. And having the seats according to the rules of physical distancing, all of those will be helpful in preparing your triage, a safe triage area. Visual alerts is equivalent to posters, so that you tell them about hand hygiene, tell them about cough etiquette, and tell them about cleaning the environment, and of course, wearing the mask. Okay. The respiratory waiting area, the waiting areas, if maybe some of you would recall, before the pandemic era, our waiting areas are really like really crowded. This time that can't happen anymore. You have to redesign your waiting area so that people would sit 1 meter apart. Even if one person has COVID, he should not infect the others by being physically distanced and wearing the mask. The triage process needs to be efficient. It should not cause the lines to be very long and very slow. If it's possible to have algorithms, so people are forms are easily filled up, and disposition is quick and efficient. For countries with widespread community transmission, such as like in the Philippines, there needs to be some kind of algorithm. So this is what the CDC recommends. We should identify immediately in our triage areas people who have fever, and then any of the symptoms. So if that's the case, make sure the patient has mask and place them already in definite areas in your emergency room. If they have no signs of what looks like COVID-19, then they can proceed to another area for further evaluation. That, as I said, the triage area should follow some kind of a clear flow that all the staff knows about. And if a patient is high risk for COVID-19, that person needs to be immediately isolated so that he or she is already at once separated from other unsuspecting people who might get the infection. So, this particular part of the triage process is very important. We need to be prepared, we need to have the forms, we need to know what to do, and we need to have an area where we can immediately separate the patients without, again, be sensitive to their needs. And whatever area we will be preparing should be comfortable and safe. In the triage area, because this it could be potentially dirty and maybe a place where a lot of people might converge, it's important we have also rules about cleaning, keeping the area clean for new patients to come in. So, what can healthcare workers do? So, we need to follow all the infection prevention and control precautions that we've been talking about for the last hour or so, from precautions to cleaning and disinfection, and the wearing properly of PPEs. Okay. Um, So there are what we call aerosol generating procedures that need to be specially mentioned because they're put healthcare workers at higher risk for getting the infection. Here are basic hand hygiene for the students. Don't forget, I'm sure all of us by now know about hand hygiene. Before, it used to be very difficult to remind people about hand hygiene, but now with this pandemic, it feels like everybody is harmonized into trying to keep our hands clean and trying to prevent ourselves from getting the COVID infection. Some of the important measures that you need to put in place in the triage is to avoid overcrowding. So, manage the crowd with good strategy for scheduling, telemedicine, a good waiting area. And if needed, you might need to expand hours of operation so that they don't need to converge over a short period of time. And as we said, try to make the place, we're all not prepared to have a COVID hospital, but we need to innovate and we need to create spaces that will be safe for not only the patients but for their families and also for our healthcare workers. So again, the CDC has a really nice series of slides that you can download and use accordingly. So here I will just go over. Please, I apologize if I'm over staying longer on this lecture, but I will finish in a few minutes. Step one, to prepare your ER. Download all the things you need. You'll need the websites of WHO and the CDC are there to help us prepare. There's like tools, checklists that they've published so that we all are synchronized and optimized in terms of preparation. Follow the hierarchy I told you about. Okay, and before the patient comes, plan accordingly. Make sure that you've prepared the area well, not only the physical structure of the area, but also the ventilation and everything else. So have networks in place so that, for example, oh, you don't need to go to the ER, you can just go to the clinic. So you need some kind of a network to work with. Okay, put up a lot of signs so that your patients are guided accordingly. Now, step two, really in this time of pandemic, explore how to limit face-to-face consultation. So if you can reschedule non-urgent appointments. You know, some of our dermatologic problems may not need to be seen in the emergency room at this time. Maybe you can reschedule them in a future date. That's what this slide means. Okay? And maybe some of the needs may be responded to well by a telemedicine type of care. Step three, make sure you teach your staff. For the students, make sure you study well before you enter the triage area. So educate the staff, make sure everybody knows what to do, and train the students how to advise. So students, many patients will have many questions, so you keep on reading so that you're able to answer the questions of your patients in a right way. So no fake news, just the right kind of information must be transmitted to them. And of course, students, please wear the proper personal protective equipment as taught to you by your school. For administrators, prepare for absenteeism. So always have a backup plan just in case your staff doesn't come in the morning. Step four, invest on basic engineering controls. So if this means uh, redesigning your space and putting more supplies. Like before, we used to be scringy on tissues and alcohol. Then now is not the time to do that. Now is the time to like put out everything you have to protect everybody. Um, Physical barriers, signages, curtains, acrylic barriers are all good and can be used. Step five, decide if you need to have add-ons to your current ER. So if you think you're already okay, then go ahead. But if you need more plastics, more acrylics to work as barriers, then do so. Assess your individual situation. Are your information desks okay? The triage area is okay? Are the payment counters okay? So look at all the needs, okay? And remember, all of us have some risk when we go to work. So address all these risks and try to get them as low as possible. These are some of the barriers I've been talking about. So if you think you need them for desks, for counters, for triage places, then start um, investing on them. And of course, air conditioning. We don't need to turn off our air conditioners. We just need to direct the air that comes in and goes out well, and treat the potentially contaminated air accordingly. Okay, so redesign your spaces. Um, okay, I'll move on. Okay. You might want to put in more UV light, which is very efficient. When the census of your emergency room or triage areas is low, maybe you can consider using UV light with precautions so that it's used again safely. So these are, for example, areas in the ER that you think might have more burden of infections. Then you can put mobile UV light systems there. Okay. Or if your ER is very huge, then you can actually create something like this, similar to systems that are put in airports, for example, to reduce the amount of microbial burdens. About foot baths, it's become very popular in the Philippines, but actually there's no basis for the use of foot baths, so you don't have to do it. Okay, no clear scientific evidence. And for special populations, please just design your emergency rooms so that our senior citizens and people who may have other comorbid conditions or immunocompromised states are taken care of in this pandemic period. Okay. Make sure step 6 is to comply with administrative controls. That means if there are rules, follow them. If there are rules about who should get the RT-PCR, then there's like guidelines about who should get them and who doesn't need them. And follow the flow of patients so that people don't get unnecessarily exposed. So designate certain ERs to be isolation rooms. Okay. I'm getting almost to the end of my talk. This is the one I was telling you about. There would be a need for some aerosol generating procedures. So, for example, a patient is very short of breath. You need to put in a special tube called the endotracheal tube. So that's an aerosol generating procedures. The person who would be assigned to do this must be specially prepared. They must wear the proper PPEs and proper respiratory protection so they don't get infected with the aerosols of the patient. So this is the, and actually there's the N95 fit testing. Recently there's a problem about N95s not being available anymore. So a lot of alternatives have come in. So we need to study them if we're setting up an emergency room. I think we need to make sure that we have enough respiratory equipment to protect our healthcare workers. And one of the options is having this N95 fit testing to make sure that people are wearing the right masks accordingly. This is our fit testing sessions in our hospital. So we take time to make sure that people have the right masks so that they don't get inadvertently infected. Okay, so fit testing is very important, especially if you opt to use something like KN95s, and it can be life saving. So for all of you who are listening to me, this is one of the important messages that in your PPEs is probably the mask that's the most important. So take time to uh, invest time and invest money on the N95. And if you're using KN95, make sure you have them fit tested, especially for aerosol generating procedures such as what's indicated by the Philippine College of Surgeons. Step 7, stock up on your right PPEs. So uh, just that you know you have enough. People, there's probably a lot of PPEs you need to buy. We've heard a lot of news about that, about sometimes having low stocks and making the healthcare workers at risk for getting infections. So what we've tried to do in PGH is really to conserve PPE. So there's a really a we really planned. It's a planned. Uh, we really planned it such that we are actually budgeting the amount of PPEs that are assigned to the different areas. You see, we have over 4,000 employees. So, and the COVID areas take about 1,000 employees. So, on a daily basis, there's a lot of PPEs that are used. So we need to really conserve their usage. Otherwise, we'll run out and people will get into trouble. Step 8, prepare yourself well on every duty day. So that means we're all ready for whatever who comes. Now, we're not sure whether patients do have COVID or no COVID, so we need to be ready for them. Uh, make it easy for your staff to implement infection control. So don't make it difficult for them. Make sure that the things they need are right there, handy when they need them. And step 9, after each patient, clean up. Don't wait for the end of the day. After patients are assessed, either facilitate if they need admission or if they can go home, give them instructions to go home. And use reliable disinfection. Again, invest on good disinfectants. In disinfect not only the surfaces but also the air because it's important. So you can use natural ventilation, open the windows, or use HEPA filters, or use UV light. These are the options for cleaning the air. And finally, use every opportunity, patient visit into your ER to teach patients about COVID-19 and how to protect themselves. So, other safety reminders sometimes after our duty in the ER, we're so tired, we want to huddle up with our friends, but we have to remember that even after duty, we need to practice social distancing. So, remember that because sometimes it's the source of our infections. And when you leave the hospital, don't forget again that the risk continues even in the community. So when we leave our hospitals on our way home, we should again be trying to protect ourselves from the COVID infection. So, all of this, the principles we hear over the television and the radios, as in the community, we need to practice all of this also inside the hospital. Remember that it only takes one patient lost in our hospital, which we cannot triage adequately, and that will lead to more and more and more infection. So we need to make sure that our health facility is able to cope up with COVID-19 and maintain safety. That's it. And these are my acknowledgements. Thank you very much. Salute to all of you who are current and future frontliners. Thank you very much for listening.
Thank you, Doc Barba.
Okay. Thank you so much. Yeah. Okay, thank you so much, Dr. Regina P. Berba, now to share his experience about the topic TRIAGE protocol in the COVID-19 emergency environment. Now, second share is the graduate from Our Lady of Fatima University and is currently taking up a Master of Science in Nursing, Medical and Surgical Nursing at Centro Escolar University, Manila. He is now a staff nurse in the Department of Pediatric Ward 9 and also an UP Agnayan ang Pahinungod volunteer at Philippines General Hospital. Please to Mr. Mark M. Galempi, time is yours.
Hello, good day everyone. I hope everyone's fine and safe from COVID. Hello to the 217 participants. I hope you're all still there. I know you're all hungry because it's lunchtime, and I hope our sharers and lecturers fill you with knowledge about COVID from our first lecturer, and especially to Dr. Berba, who shared a lot of information about COVID and how we can protect ourselves in COVID. So, by the way, I am Mark. I'm nurse 2, pediatric nurse from the Philippine General Hospital. I am currently assigned the pediatric COVID unit, and I've just finished my night shift duty a while ago, so please bear with me. If you have questions, you can chat here at the bottom part of the screen so I can see it. If you have questions, and you can react also with thumbs up if you agree. Okay, so I will be sharing with you my experience regarding triage protocols in the COVID-19 emergency environment. Although I'm not assigned at the emergency room, I'm assigned at the COVID unit, which is one of those areas um, in this position after the triaging in the PEDJER. So being a COVID nurse assigned at the COVID unit, this is perhaps the most challenging, if not is one of the most critical trials in my career as a nurse. Challenges such as staffing, we're still understaffed, especially right now. New work setup from ward setup to intensive care unit setup. Wearing PPE. Is anyone here experienced wearing PPE? The challenging part in every duty is the PPE wearing, donning and the doffing. And miscommunicated protocols and guidelines are only among the few problems we have encountered during our duties. I am originally from the non-COVID pedia ward, which is the ward 9. And our sister ward, the ward 11, was the one to handle the pedia COVID cases. As the pandemic situation worsens, one after another, the top-ranked hospitals in the Metro Manila were already overwhelmed by the increasing COVID-19 cases and were already refusing new admissions. It was then that the Philippine General Hospital, our hospital, was designated by the Department of Health as one of the 3 referral centers in the National Capital Region. Staffing problems had arisen when our nurses started to get sick also. We already have 141 staffs in the PGH who are tested positive with COVID-19 as of June 15. And 5 of them are my co-staffs in the pedia ward. So our older nurses and those who have comorbidities were advised not to be assigned in the COVID areas. It is when we, the younger nurses, were reassigned to COVID areas, and we took the challenge wholeheartedly. So let me share with you the protocol. Quick rundown, because Dr. Berba have shared earlier about the algorithm in triaging. So let me share with you. Can you see it, guys? So here's the algorithm of a patient. When a patient walk in the ER, they will be seen and triaged by the PEDIA ER resident on duty. The patients for assessment will be given surgical face mask, as what Dr. Berbas already told us, and the residents will then coordinate with security to the residents may bring the patient to the PEDIA ER holding area, which is in the hallway for assessment. If the patient is a COVID suspect with mild symptoms or unlikely COVID with non-urgent symptoms, the patient will be charted by the residents and advised accordingly. If the patient is unlikely COVID, sorry, let me share that. If the patient is unlikely COVID with non-urgent symptoms but requires admission for medical or surgical care, sorry, here, more clear version. If the patient is unlikely COVID with non-urgent symptoms but requires admission for medical or surgical care, the PEDIA ER resident will coordinate transfer to another hospital. Can show here. Here. If the patient is COVID suspect with moderate to severe symptoms and unlikely COVID with urgent symptoms, the patient will be admitted to the PEDIA ER holding area for appropriate management. And all patients at the PEDIA ER holding area will be referred to INTROP. INTROP is infectious and tropical disease in the pediatrics for screening based on clinical history and chest X-ray. All patients at PEDIA ER will be swabbed for RT-PCR by the PEDIA ER resident on duty. So if the patient is deemed to be unlikely COVID, the patient will be admitted to the Ward 9 holding area pending the RT-PCR result. And if the patient's RT-PCR results are negative, the patient will be transferred to the main area of the Ward 9. And if the patient's RT-PCR is positive, the patient will be transferred to room 518. And lastly, if the patient is deemed to be COVID suspect, the patient will be admitted to room 516. If the patient's RT-PCR result are negative and clinically compatible with the COVID, the patient will be transferred to the main area of the Ward 9. If the patient's RT-PCR results are negative but clinically compatible with COVID, the patient will transfer to room 517. These rooms are located at the 5th floor in the COVID area. And if the patient's RT-PCR results are positive, the patient will be transferred to room 518. In the COVID unit, there are a maximum of 11 patients admitted in the pediatric COVID ward. The primary service for all patients admitted will be INTROP. All patients being managed by specific team will be managed until the end of the admission. If new consultants are on deck, they will be received referrals of the new admissions. If highly considering COVID patients, will be referred to allergy immunology service. If on oxygen support or requiring intensive care patients will be referred to pulmo or PICO service accordingly. According to the protocol, there will be no watchers allowed inside the 5th floor. Prior to admission, watchers will be instructed that they will be contacted by the COVID duty team regarding status and needs for their patients via text message using a designated PEDIA COVID phone. However, should there be a valid reason for a watcher to be admitted with a patient, the watcher must sign a waiver and wear at least level 3 PP at all times. Residents in the ER will be in charge of updating relatives of the current status of the patients. And once patient is for discharge, PEDIA INTROP fellow will give final instructions. All follow-ups will be through telemedicine. So, to summarize the protocols, all patients walk in and from coordinated transfer from other hospitals directed to PEDIA ER residents or fellow on duty. And the resident or fellow on duty will be the one
Correct.
to assess and refer for appropriate management. So there are 5 areas of disposition for patients. 2 areas in Ward 9, the holding area and the main area of the Ward 9. And there are 3 areas or rooms for the Pedia COVID unit. The room 516 for COVID suspect, the room 517 for probable cases, and room 518 for confirmed positive. Ward 9 has 21 bed capacity, while Pedia COVID has a maximum of 11 bed capacity. As of now, we have 7 patients in the Pedia COVID unit. May I remove the format? So sorry, how may I remove this? Stop share. So these protocols, I'm sorry, so hot in here. These protocols and guidelines were made due to diligent studies by the administrators. But there are instances that arises in the actual setup that are not within the scope of these guidelines or protocols. So I'm gonna share with you my experience of what happened during our duties. So one interesting example is our COVID positive patient is a 10-year-old boy admitted to one of those rooms in the 5th floor, and he developed depression and he is showing self-harm. He was alone in the room for several days, and he want his father to be there with him to take care of him. But in the initial protocol, it doesn't allow a watcher in the COVID area. That boy, that patient, threatens to jump in the window, and we're in the 5th floor. We can only do as much as talk to him in just a limited time because we can't be at his side every minute. One day, during his video chat with our social worker, he suddenly stabbed his body with a ball pen. They were alarmed, panicked, so they called immediately the nurse station to check on the patient. Fortunately, the patient wasn't that harmed. Eventually, after discussions with the Pedia heads in the HICU, they have let the father accompany his child with approval from the heads of the Pedia department and the HICU. It has dramatically helped our patient, but the question is there a breach in the protocol in that instance where we let the father accompany his child inside the COVID area? Eventually, they revised the protocol and let a watcher inside the Pedia COVID unit if there's a valid reason, and as long as the watcher or the parent wears level 3 PPE at all times. But then, we only have limited resources of PPE. So they have let the father wear face mask and gloves, level 2 PPE. And again, was there a breach of protocol? The patient did recover from COVID-19 eventually, and they were discharged together with the father after they were tested negative in the swab test. So protocols and guidelines are made to be precise step-by-step instructions that needed to be done meticulously. And so it takes time, and time is vital in an emergency situation. When I was still at the non-COVID area or the Ward 9, one of our patients was coded. An intern called the code, but instead of initiating CPR, the intern ran to the room to wear PPE and called the other doctors. I was the one who ran to the patient and initiated a resuscitation with just a minimal protection of level 2 PPE, wearing gloves and surgical face mask only. The doctors came after a few minutes with their level 3 PPE because I think that was the protocol at that time, and we weren't informed yet. The child did not survive eventually. He was not tested for COVID-19 though. He was admitted due to other comorbidities. It happened a few months ago when the COVID-19 cases are still starting to rise, and PGH was not yet a referral center. But what if that child turned out to be positive in COVID-19? I could have been infected. The whole pedia non-COVID ward could have been exposed to the virus. I could have spread the virus because I selflessly initiated a CPR during code blue because someone didn't do it. Or is it of a new protocol or guideline which is miscommunicated? Another more recent instance is when I was already in the pedia COVID unit, when our pedia patient with cardiac comorbidity was coded. She is a probable case of COVID-19 without a confirmed test result. I assisted the resuscitation, and since all of us are already wearing level 4 PPE with complete coveralls and goggles and the face shield, we are supposed to be safe. But the doctors are having difficulty intubating the patient due to poor visualization from the foggy goggles and face shield and the sweats and everything. And also the aerosol box that have been shown to us by Doc Berba earlier. It made us more difficult for us to do resuscitative measure. But we don't have other choice. And we cannot remove our protective equipment. That was the protocol. The child had succumbed to the disease later on. If we could have done more, if we could have done better, if not restricted by the protocols and PPEs, we could have saved the child, perhaps. But the truth is, there is no such thing as emergency during a pandemic. Every one of us must be prepared and well protected before going to the battlefield. We can't do anything if we don't have proper protection, which is our PPEs and well-communicated guidelines and protocols. Doing nothing may be the hardest thing to do, especially if you know you could do something vital. Doing nothing doesn't benefit the patient and might only cause further harm. It's unethical. Many of us would say we could never do that to our patients. Compassionate nurses and doctors said the same thing. And many did run in to help, saying, PPE be damned, my patients need me. Then they become infected. They infected others and they died. They didn't help anyone after that. We on the frontliner are force multiplier. Our training and experience is a game changer and invaluable in moving forward and fighting through this crisis. So even if we are facing these difficult challenges that I have mentioned earlier, we have to consider our safety as well. We need a complete and not reused PPE. We need proper staffing, proper patient and nurse ratio. We need properly communicated and well-established guidelines and protocols. I hope you've learned something from my share and my experience in the COVID. The past lecturers, Dr. Berba, they've already explained everything. So with that, I end my sharing. Thank you for listening.
Okay, thank you so much, Mr. Mark M. Garingpin. Now, for our final speaker, who will speak about the topic nursing responsibility in caring for COVID-19 patients. She graduated in the year of 2005 at Depok, Indonesia, and also took up her master in nursing at Depok, Indonesia, or Indonesian of University in the year of 2016, and her specialization in the medical surgical nursing in the year 2017. She is the inpatient coordinator of the Persahabatan Government Hospital. May we call on Nurse Dede Komalawati MKEB. Please, time is yours. Okay, Miss Dede. Okay, thank you.
Thank you very much. Thank you for the opportunity to share the sharing in caring for COVID-19 in Indonesia, especially in Persahabatan Hospital. Introduction. We know coronavirus is reported to have begun to emerge in Wuhan on December 12 2019, spreading throughout the world, including Indonesia. WHO COVID-19 is pandemic. Patient in Indonesia on that June 14 is confirmed 40,042 infection 21,053 death 2090 that well 13,077 and in Persahabatan Hospital until 60 June confirmed from February is confirmed 2063 inpatient 799 in dead patient 92 and go to home 160 and that until in Indonesian 16 disease positive or confirmed that and go to home and death is patient. What is COVID-19? We know coronavirus are large family of virus that cause illness ranging from the common cold. Animal with coronavirus can develop and infect disease. Sign and symptom. Next, include fever, cough, shortness of breath, fatigue, anorexia, sputum production, sore throat. And high risk population, older people more than 72 years of age. And people with serious chronic illness include diabetes, cardiovascular, chronic respiratory cancer, hypertension, chronic liver disease. And in Persahabatan Hospital, patient COVID more with comorbid diabetes, cardiovascular, and hypertension. We know transmission COVID with droplet and direct or indirect contact. The incubation between 2 until 14 days. And diagnosis COVID-19 detection PCR and can be rapid test, but in Indonesia, di Persahabatan Hospital unsure PCR and laboratory if the patient entry to inpatient examination in hematology routine, kidney function, electrolyte, analyze blood gas, hemostasis, lactate, procalcitonin. In procalcitonin, in hematology, and radiographic, usually his patient bilateral consolidation. This is SOP. SOP, his patient swab examination day 1, day 2, day 4, day 7, day 9, and 14. If one positive in day 1, day 2 negative, his patient doing to swab in 90 days. In pathogenesis, coronavirus into the cell induce the release cytokines. If cytokine to cell we are found EL1B and possibility the stimulation T helper 1 and T helper 2. T helper 2 additionally increasing T helper 2 cytokine with surprise inflammation is different from SARS-CoV. SARS-CoV is related to the degree of severity. And severity of the case COVID is without symptom, is like this and no symptom, if mild, uncomplicated airway infection, medium pneumonia, but doesn't oxygen supplementation, severe, his patient dyspnea, hypoxia, pneumonia, respiratory disease, saturasi oxygen, less 93%. Critical if his patient multi-organ system dysfunction 5%. And complication is if 90 COVID entry to cell receptor ACE2 stimulation lymphopenia and activasi myeloid cell. Cytokine storm that hypercoagulability and microangiopathy, acute cardiogenic and lung injury can his patient in sepsis. And his patient kidney can be acute disorder, acute kidney disorder, heart injury, pneumothorax, liver dysfunction. This is, for example, case study in Persahabatan Hospital. Mr. Y, 62 years old, undergraduate education, civil servant, come to Persahabatan Hospital on 2 June 2020 from emergency room with diagnosis COVID-19, IgG rapid test result reactive. The result pneumonia from X-ray. His patient complained of cough, shortness of breath since 5 days, fever, headache, muscle ache, body weakness. With COVID patient don't know awareness of compose mentis, DCS, I4 motoric, 6 and verbal 5 and vital sign. This is 130 to 70, heart rate 96, and respiratory rate 32 minutes, and temperature 38 or 5. For examination pulmonary, auscultation, Ronhi positive, through the lung field, wheezing positive, Putum positive, CRT 23 readed. Mr. Rie said he was worried about his current condition and thought of his children and his wife at home because he was not can meet his family. The investigation, this is the result, hemoglobin, hematocrit, leukocyte, platelet, neutrophil, lymphocyte, and analisa lab gas, PCO2 33, and nursing process. We now nursing assessment his patient travel history or contact, physical examination, problem mild moderate, ineffective clean airway, gas exchange disturbance, anxieties. Can his patient severe problem, spontaneous ventilation disorder, and shock risk. If his patient severe problem, patient refer to intensive care unit room. Nursing care plan goals and intervention, vital sign, oxygen saturation, respiratory isolation, enforced hand hygiene, mechanic ventilation, educate the patient, and fog. And clinical management, mild to moderate disease and severe. For the mild to moderate disease, monitor inpatient or outpatient. In Persahabatan Hospital, inpatient have 5 wards, and outpatient in poly ODP and supportive care potential rise factor or severe disease and the ability of the patient to self-isolate at home. Isolation at home 14 days, and severe disease inpatient management to supportive management, complication, for example pneumonia, hypoxemia, respiratory failure, sepsis and septic shock and cardiomyopathy, arrhythmia, and acute kidney injury. This is intervention, airway management, high flow nasal cannula, reduce anxiety, isolation management. Ineffective clean airway, monitor breathing pattern, secret monitor, monitor the ability cup effectively, position bowler. Airway management, give warm drink, do mucus suctioning for less than 50 seconds. This effective technician, bronchodilator, or mucolytic collaboration. Sign emergency warning, if the patient difficult breathing or shortness of breath, persistent pain or pressure in the chest, new compulsion or inability to arouse, blaze lips or face. This is observation for the patient inpatient EWS COVID-19. This is in scoring 0, 1. For example, respiratory patient 1 until 11 in scoring 1. we are observation RR, respiratory rate, saturasi oxygen, blood pressure, pulse, consciousness, and temperature. Gas exchange disturbance, we doing monitor breath sound, monitor oxygen flow velocity, monitor integrity of nasal mucus, clean secret from mouth, nose, trachea, collaboration of oxygen with the doctor, and reduce anxiety, monitor anxiety sign, where his patients are allowed to bring mobile phones for communication with family, not to be visit because they have to be isolation, or if there are complaints, easy communication. This is his patient in patient of the flow or high flow nasal cannula. High flow nasal cannula therapy is beneficial in patients who breathe spontaneously but have increased breathing. Condition such as general respiratory failure, asthma, and COPD. If the patient severe hypoxemia, due to prone position, but prone position from the research to reduce mortality rates on the condition that the patient must be sedasi so that the endotracheal tube is not removed. And his patient CRRT, about 70% of patients who enter the intensive care unit experience acute kidney failure. Therefore, the existence of CRRT for replace the function of the kidney in critical times. There's isolation management. Isolation management, his patient in cohorting, for example, COVID with COVID positive, negative and negative, and rapid positive and rapid positive. For isolation management, identify patient who need isolation, play a patient for one room, but limited room in COVID-19, this patient can the patient one word. The contamination, medical equipment possible after use. This documentation guideline, if each patient can to what 90 COVID, this patient in initial assessment form, disease, include affecting interaction, nature of social exchange, specificity of individual behavior. This is in documentation in assessment, initial assessment. And in documentation in for intervention and evaluation in CPPT integrated, but documentation can the doctor, nurse, nutrition, and or health worker. And this is from observation form. This is content, vital sign, saturasi, oxygen saturation, temperature, intake output. Nursing responsibility in caring for COVID-19, providing frontline care in the most patient-facing role to complex COVID-19 case that required hospitalization and communication. This is information. Information is placed in banner which is passed the general community. And nursing education staff for PPA corresponding SOP health worker management transmission COVID small PPS and
Abah.
Cleaning the environment to reduce transmission of the coronavirus with liquid sodium hypochlorite, and ambulance with carrying refer to the patient, text refer patient, transfer or text body. This is if will transfer patient and use ROS tool. This is with chamber. This is chamber, and if brancar, this is in Persahabatan Hospital. If transfer patient, and his patient infant. Where to facial if his patient female, facial color pink and male color blue. This is next before to the patient. Nursing wear the surgical gown if not yet enter into the patient. In N95 handskun, cover shoe, this cover shoe, handskun, face shield, hazmat, and we are PPA for where to step by step is SOP.
Mohon izin Ibu Dede, waktunya 5 menit lagi.
Yes, this is if the patient entry to the door and PPA remove room. For example, masker in masker. This is container and SOP step by step remove. And exit for the remote different for the entry. Then take bed if already his patient. In prevention, vaccine, early detection, hygiene, hand washing. There's a return criteria his patient if the clinical condition has improved, virology test, and negative twice in a row. This is a regulation in Persahabatan Hospital if his patient, there is a written criteria. And discharge planning might need some extra support, self isolation. His patient, education. His patient if patient and family are given leaflet after education, put eaten, independent isolation, drink, therapy, and control when is control his patient. And education, provide education to family every day at 11 o'clock by providing update patient development information in advice persahabatan hospital and his patient absent his family patient. This is if his patient control in poly control and his patient, thanks patient who have recovered. His patient death for ambulance. I think for the disinfection, if his patient already. Thank you very much.
Okay, thank you so much, Nurse Dede Komlawati, MKEB SPKMB for Persahabatan Government Hospital Indonesia. Now, to share her experience about the topic nursing responsibility in caring for COVID-19 patients. She is a graduate from Trinity University of Asia St. Luke's College of Nursing. She studied Master of Art in Nursing Administration at Centro Escolar University and is currently taking up her doctoral in Nursing Management at Trinity University of Asia. She took up pulmonary and critical care nursing specialization at Lung Center of the Philippines in the years 2013 and has been rendering service originally at Medical Surgical Unit for 4 years before being deployed to COVID floor at the Lung Center of the Philippines. So please to Miss Jennifer Rai Ki Lim, time is yours.
Good day everyone, I am Jennifer Lim, currently assigned on COVID areas, and I am here to share about our nursing responsibilities with COVID patients. COVID-19 is a disease caused by newly discovered coronavirus. Most people infected with COVID-19 will develop mild to moderate respiratory illness. The first thing that we have to do is to fully equip ourselves with personal protective equipments like coveralls, N95, face masks, face shield, and booties before going to patients. And of course, standard precautions should be observed at all times. In Lung Center, taking care of our patients is secondary to taking care of our health personnel. High priority with regards to staff safety was given in order to save thousands of lives. One of our game plan was to look at each other and make sure that we won't break any infection control protocol. We also have to be extra mindful with our device foot traffic flow inside the hospital that will prevent the contamination of the supposed safe zones. For us nurses, it was difficult to adjust in doing our rounds, especially that we have to wear our PPEs. It was really difficult to move, but we have to protect ourselves and our patients, so we have to be fully equipped. We also have to be extra mindful on designated areas of doffing and donning. COVID-19 virus primarily spreads through droplets, so one of the nursing responsibilities is to teach patients proper respiratory etiquette. One example is coughing through flex elbows. Another responsibility that would be very important is to have a thorough patient assessment. The success of our intervention would fully depend on proper and correct nursing assessment. Monitoring of vital signs, oxygen saturation, and GCS level would be very important. Most COVID patients won't show early symptoms of the disease but would manifest oxygen desaturation and infrahalar airspace opacities on chest x-rays. Any deviation on baseline data should be assessed as soon as possible for it to be managed on early stage. Patients who are under solidarity or investigational drug trials should be closely monitored, especially their cardiac rates and heart's electrical activity, as these drugs causes cardiac disturbances. As of June 8, 2020, Lung Center has the highest number of patients under solidarity trial. It is really a challenge for us specialty nurses to be handling COVID patients since it is not solely a respiratory condition, but these patients have comorbidities. Assessment of COVID patients in our institution is also a challenge since COVID patients also presents signs and symptoms of other respiratory and chest diseases. Another helpful nursing intervention is to do prone positioning from 12 to 16 hours as this allows oxygen to easily get into the lungs. It takes a lot of patience and strength to prone position a patient, especially if these patients are critically ill. It will take 5 to 7 individuals to properly prone a patient. Well, if we really wanted to promote lung expansion, then we have to be extra vigilant and religious in doing this intervention, as this may aid in faster recovery. Nebulization, open suction, and use of bag valve mask on ventilated patients should not be allowed, as to avoid transmission. Nebulization should not be done. Use of bag valve mask is not allowed. Use of aerosol bags for intubation is advisable. Closed suction system should be done. Moreover, planning on being fully efficient nurse during our rounds is another challenge since there is lack of resources and time inside the room will be also limited. Providing psychosocial support to our patients was another hard shell to crack. Because once admitted at COVID unit, these patients become isolated and away from their family. Hence, this aids into increasing stress, frustration, and anxiety that may cause poor mental well-being. Psychosocial support must be well provided and maintained. Lastly, nurses should be extra cautious and follow strict guidelines on infection control together with in-depth assessment and hands-on nursing management and intervention. It was also hard and frightening for us to be fighting at the front lines, trying to save lives, and at the same time, keeping ourselves protected from the virus.
525,600 minutes
Thank you so much for our third sharer, which is Miss Jennifer Ray Jaylin. Now, to share her experience about the same topic, nursing responsibilities in caring for COVID-19 patients. She is an alumna of Budi Luhur Institute and now is a staff nurse of Al Isan Government Hospital, Miss Ernie Gumilar.
Meron na tayong kape, meron pala doon. Nakita ko yung kape, natatabunan lang ng coffee mate. Oo.
May we welcome our fourth sharer from Indonesia to share her experience about the same topic, nursing responsibilities in caring for COVID-19 patients, Miss Ernie Gumilar.
Okay, thank you, moderator. My name is Ernie Gumilar. I work at Al Ihsan Hospital since 1997 until now. During this pandemic, I was assigned as nurse to handle COVID-19 infected patient in the isolation room. On this occasion, I was with experience in handling patient infected with COVID-19. I want to give a little experience about the role of nurse in handling COVID patient. I'm sorry, I request permission to use two languages, Indonesia and English, because my English is not good. Baiklah, sedikit saya akan membicarakan tentang peran perawat, khususnya di sini peran perawat dalam menangani pasien yang terinfeksi COVID-19. The role of the nurse is the behavior expected by others toward someone in accordance with the population in the system, which can be influenced by social circumstances, both from the nursing profession and from outside the nursing profession. Jadi peran di sini adalah tingkah laku yang diharapkan oleh orang lain terhadap seseorang sesuai dengan kependudukan dalam sistem. Perawat harus bisa merubah tingkah laku, terutama pada pasien dengan COVID-19. Mungkin di sini ada 7 peran sebagai perawat. There are 7 roles of nurse. Yang pertama, nurse as the role nurse provider of nursing care, caregiver. Jadi peran perawat di sini memberikan asuhan keperawatan 24 jam, terutama pada pasien COVID-19, sesuai dengan tindakan keperawatan yang dilakukan dari awal sampai dari pengajian sampai evaluasi. Di sini perawat sebagai peran yang utama di mana perawat akan terlibat aktif selama 24 jam dalam memberikan asuhan keperawatan, terutama pada pasien COVID-19. Perawat yang terus-menerus mengobservasi selama 24 jam. Mungkin di sini saya pengalaman sebagai perawat di ruang isolasi COVID. Kita mungkin sama dalam memberikan asuhan keperawatan seperti pada kasus lainnya, tetapi mungkin perbedaan di sini karena ada protokol kesehatan bahwa kita harus memakai APD. Jadi dari mulai awal pengkajian, pendekatan kepada pasien sampai evaluasi tindakan yang harus dilakukan. Tindakan yang dilakukan sesuai dengan awal pengkajian Tuhan utama pasien. dari berbagai sistem, mulai dari sistem pernafasan, nutrisi, sistem yang lainnya, bio, psikososial, dan spiritual. Kemudian, then nurse advocate. Jadi peran perawat sebagai advokat is to help patient and families reduce the stigma for patient and families who are indicated positive COVID-19. Jadi perawat sebagai advokat membantu pasien dan keluarga, yaitu mengurangi stigma bagi pasien, terutama stigma negatif bagi pasien dan keluarga yang terindikasi COVID positif. Karena pengalaman banyak keluarga yang keluarga pasien yang keluarga pasien yang dirawat di isolasi COVID merasa ada stigma negatif, terutama dari daerahnya, terutama dari kadang keluarga juga ada. Jadi perawat ini membantu sebagai advokat. And then nurse as educator. Peran perawat yang ketiga yaitu nurse as a team of educator provide education to patient and families and society. Jadi perawat itu sebagai pendidik, memberikan edukasi kepada pasien, keluarga, dan masyarakat. Perawat berperan dalam memperkuat pemahaman masyarakat terkait dengan apa dan bagaimana COVID-19, pencegahan dan penularan, serta bagaimana meningkatkan pengetahuan masyarakat tentang tanda dan gejala. Hal ini dilakukan dalam rangka meningkatkan sense of crisis sehingga masyarakat menjadi waspada dan menerapkan perilaku pencegahan dan hidup sehat serta tidak panik. Yang keempat, peran perawat nurse as coordinator. This role is carried out by directing, planning, and organizing a health service from the health team so that the delivery of health service can be directed and is according with patient need. Jadi harus mengkoordinasi apa yang dibutuhkan pada pasien dengan COVID-19. And then nurse as collaborator. Jadi nurse work through a team consisting of doctor, physiotherapist, nutritionist, and others with effort to identify the nursing service needed, including discussion or exchange of opinion in determining the next part of survive. Jadi di sini sangat perlu kolaborasi antara perawat dengan dokter, dengan fisioterapis, dan dengan nutrisionis gitu, dalam perawatan pasien COVID-19 ini. Yang keenam yaitu peran perawat sebagai konsultan for patient. Nurse act as a place of consultant for problem or appropriate nursing action to be given. Jadi perawat sebagai konsultan bagi pasien, sebagai tempat konsultasi terhadap masalah atau tindakan keperawatan yang tepat untuk diberikan, terutama pasien-pasien dengan COVID-19 selama dirawat di ruangan tidak ditunggu oleh keluarga. Jadi perawat yang selalu memberikan pendekatan dan sebagai konsultasi dari pasien apapun yang ditanyakan sama pasien, karena perawat yang terus mendampingi pasien selama 24 jam. Dan yang ketujuh itu peran perawat sebagai pembaharu. Mungkin di sini there's reformer ya. Nah, mungkin di sini saya tekankan bahwa peran perawat ini sangat perlu dijalankan dalam membantu mempercepat kesembuhan pasien dengan COVID-19. The role of the nurse is very important to help speed the recovery of patients who are infected with COVID-19 and help breaking the chain of COVID-19 infection. Perawat emang harus selamat untuk menyelamatkan orang lain. Nurse must be safe to save others. Jadi pengalaman saya selama merawat pasien dengan COVID-19 berbeda-beda respon dari pasien dan ada yang setelah beberapa minggu, ada yang hampir sebulan pasien dirawat. Jadi tergantung dari daya imun pasien juga. Jadi di sini perawat butuh pendekatan dengan pasien karena pasien merasa bahwa ini penyakit yang lain daripada yang lain. Jadi peran perawat di sini sangat penting. Mungkin itu yang bisa saya share. Terima kasih atas waktunya. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Ms. Ernie Gumilar from Indonesia. Now, I would like to thank you, or we would like to thank you, our speakers, our sharers, and also our viewers. To summarize the whole presentation, during the presentation, the questions are already being answered by our speakers and sharers from different social media accounts, where we are having our live stream. Our speakers have spoken about the importance of being knowledgeable about the standard precautions in different areas, ward, or institutions, triaging and nursing responsibilities in one of the COVID referral center of the Philippines, which is the Philippine General Hospital, and not just here in the Philippines, but also internationally, specifically by our speakers from Indonesia and New Zealand. Videos and presentations are seen, and the encouragements for the nursing students are given by the speakers and sharers. The speakers and sharers motivated the participants to continuously equip themselves with knowledge about the evolving nature of this pandemic, to be able to handle the patients with dignity, understanding, compassion, kindness, and competence in any nursing institution. This discussion has been very informative, especially for all the nursing students out there. Especially for all the nursing students out there who are preparing to become what they dreamed of in the midst of this pandemic. Evaluation forms will be sent through your personal emails, and when you receive it, please accomplish it within the same day for you to receive your certificates.
Okay, now for our closing remark, it's an honor to call on the head of the Career Development Center of Budi Luhur University Institute of Health and Sciences, Cimahi, Indonesia. Please to Ando Fikri Hakim, MAN, time is yours.
Good afternoon, everyone. May I apologize to Dean, Speaker, participant, committee, and faculty member from our President of Budi Luhur Institute of Health Sciences, Ma'am Sri Wahyuni, PhD, cannot join this webinar because she have duty in out of city. I will speak behalf of President of Sri Wahyuni. The Honorable of Dean School of Nursing, Centro Escolar University, and all of speaker, participant, committee, and faculty member. It is a great pleasure for us, for me especially, to say a few words at the end of this webinar. First, we would like to thank to all of you who can join in this webinar who conducted by Centro Escolar University, Philippines, and Budi Luhur Institute of Health Sciences, Cimahi, Indonesia. with the team Nursing the World to help breaking the chain of COVID-19 infection could be happen this webinar. From this international webinar, we have learned a lot from the material and sharing session delivered by amazing pre-invited speaker from Philippines, New Zealand, and Indonesia. Also, sharing session delivered by amazing for invited sharer from Philippines and one sharer from Indonesia that one of our alumni from Budi Luhur Institute of Health Sciences who have worked in Al Ihsan Hospital for now. Furthermore, I would like to thank our presenter and participant who have joined this webinar from Indonesia and Philippines. I'm certain that every presenter has presented the application and strategy to break the chain of COVID-19 infection. I sincerely hope that through your presentation and discussion afterward, all of us can contribute to solving the problem of COVID-19 to break of chain infection in both our countries. Even though the contribution may be small, but it's still valuable. Again, congratulations to Budi Luhur Institute of Health Sciences and Centro Escolar University to have successfully of international webinar for today. Thank you very much for all.
Thank you so much to Nurse Ando Fikri Hakim, MIN, to deliver closing remarks. So thank you for everyone to join in this webinar. And thank you so much for the crew from CEU, crew from Institute of Health and Sciences, Budi Luhur Cimahi. Thank you very much.